Hello friends, welcome to EPG Pathshala. I am Dr. Saroj Kumar Amar, working as Assistant Professor in Forensic Science Division, Lovely Professional University, Jalandhar, Punjab. I am going to focus on the module which is determination of age, sex, race and stature from human skeleton remains, which is under the paper heading of Forensic Science and Forensic Medicine. After completion of this module, a student will able to understand the basic of forensic anthropology as well as how to determine the age from bones. The learners will also able to know that the how to estimate the race and stature of individual from skeletal remains. A student can differentiate the skeleton of male and female. Forensic anthropology presents the application of knowledge and technique of physical anthropology to problem of medico-legal significance. The main goal are usually to assist in identification of human remains and to help in determination of what happening to the remains, especially with regards to the evidences of foul play. Usually the material examined consists of largely or completely skeletonized remains or skeletal evidence that has been removed from flesh remains. Forensic anthropology brings to a case technique and experience in the interpretation of skeleton remains as well as worldwide comparative population perspective. Such a perspective is needed to assess properly the probability involved and avoid the error of interpretation. Stewart defined the forensic anthropology as that branch of physical anthropology which is for forensic purposes deals with the identification of skeletal remains known to be or suspected of being human. The definition reflects the thinking at the time regarding the nature of case usually examined and the distinction between comparatively new science of forensic anthropology. The history of forensic anthropology is closely linked with the physical anthropology and related specialties within forensic science. Thus, the forensic anthropology is the application of science of physical anthropology to the legal processes. The identification of a skeleton, badly decomposed or otherwise unidentified human remains is the important for both legal as well as for humanitarian reason. Forensic anthropologists apply a standard scientific technique developed in physical anthropology to identify human remains and to assist the detection of crime. Forensic anthropologists frequently work in conjunction with forensic anthropologists, odontologists and homicide investigator to identify a decedent, discover evidence of foul play or the post-mortem interval. In addition to assisting in locating and recovering suspicious remains, forensic anthropologists work to suggest the age, sex, ancestry, stature and unique feature of decedent from the skeleton. Now the first topic of discussion is sex determination from skeleton remains. Sexual dimorphism is the skeleton reflects a history of differential selective procedures that are mediated primarily by adolescents' hormone output. The distinctive human pelvis shape as an adaptation to posture and locomotion is shared by both sexes. The added selective pressure of carrying and giving birth to large brain babies is borne only by the female. Thus, it is no surprise that the pelvis area exhibits the greatest sexual dimorphism and can be regarded as the gold standard for sexual dimorphism. Elongation Elongating the pubic body and ramus in the lateral medial direction is very efficient way to increase the prominence of the female pelvis basin. The pubic stretch produces the inverted U-shaped subpubic angle in female that contrasts with the inverted V-shaped angle in male. It is also a major contributor along the shorter female ischium length to the greater pubic ischium ratio in female. The differentiation from a skeleton does not appear until puberty. Until the puberty, a skeleton of two sexes differ only in size. Sex determination is dependable only if the vital parts of the skeleton are present in good condition. Pelvis and skull are the most important one for determining sexes. In male, a skeleton are bigger and stouter, while in female, a skeleton comparatively smaller and slender. In male, muscular ridges, depression and the process are more prominent, while in female, muscular ridges, depression and the processes are less prominent. In male, shaft of the long bones relatively rough and the articular surfaces and the end larger, while in female, shaft of the long bones relatively smooth and the articular surfaces and the ends smaller. The next important consideration is skull. Although the skull is not the next best skeleton region for the assessing sex, that extending probably below to the femur or humerus. It is commonly encountered in isolation or with element of even less diagnostic value. Variability in the degree of sexual dimorphism within and between the population probably reflect some combination of genetic and environmental factors and the life histories. Consequently, even within a population, the degree of sexual dimorphism can fluctuate on both short and long time scale. The degree of fluctuation is usually not a matter of concern, but it is a small factor that can negatively affect previous estimation of accuracy if conditions have significantly changed. The adult female skull is usually lighter and smaller, 10% less spacious than the one of the male. It is very difficult to determine sex of a skull below the age of adolescence. Assigning sex to immature skeleton has proven more of a challenge than is the case for adult. One might get the impression for infant and children the probability of error approximate that of a coin flip. The situation is really not the changey. The next topic is to focus is age estimation from skeleton remains. Estimation of chronicle age from the skeleton age is in the early years rest on measure of the growth and development. Growth is the increase in size. Size increases may be accompanied by the change in the form of function, which is development. Maturity is the attainment of adult forms and function. The age of juvenile is estimated by examining growth and development. Chronicle age estimation for adult is based on indication of aging. Aging is the universal progressive and intrinsic accumulation of deleterious changes, eventually leading to death. Probably because of more stringent selective pressure, the timing of phases and the growth and development is more regular and more synchronized among anatomical sites than in the case for the marks of aging. As a result, the inherent variability in the criteria of assessing biological age progressively increases from fetal life to old age. The degree of uncertainty attached to the age estimation likewise must progresses accordingly. The age ranges that could reasonably encompass the observed morphological stage increases with the age of disease. The large age ranges attached to estimate the age of middle age and the older adult are not so much because the techniques need perfecting as there is an intrinsic variability in the rates of aging that increases dramatically over the lifespan. This relationship holds the both and grows the macroscopic level of observation. To add to the complexity of the estimating age, significant timing difference attributable to the sex apply at all the stages of the life cycle. Hence, the adult sex is frequently known, but the ranges of age estimation remains comparatively large. For children, the age range is comparatively smaller, but the sex is often an unknown. Anthropological motivation for the assessing age at the death from the skeleton remain arises for the most part of addressing the question revolving around the archaeology. The anthropologist for anatomists and often one and the same individual apply existing the criteria and devise the new one in order to investigate the interaction between the cultural variations and the demographic profiles. The individuals who are studied are not really the focus of the analysis, but more lies the data point to be used in describing a population. In forensic anthropology, it is the individual, not the population, that are to be characterized. This distinction is not a trivial one when it comes to evaluating the system of estimating age from skeleton remains, especially when the goal is adult age estimation. Moreover, demographically oriented techniques focus on 5 or 10 years model age group with confidence interval that are rather difficult to estimate. Now going to discuss the early age estimation. The age estimation for fetal periods and early childhood depends primarily on the appearance and the fusion of major center of the ossification and on the size of various skeleton elements, that is growth and development. The appearance of ossification center is very useful in the clinic, but much less so disarticulated skeleton remains where an element might be missing because it had not ossified or was too small and undifferentiated. The early years 43 to be recognized or was the lost postmortem. As a rule, it is better to confine attention to what is present. Determination of fetal age most frequently is directed towards the question of whether or not the fetus could have been born alive. From about 3 months to on is largely a matter of size. At the 3 fetal months, long bones are tubular with no evidence of muscular attachment, and the mental suture are unfused. By the end of fetal period, the primarily center individual bones are almost all recognizable. At birth, a few secondary center of ossification, such as distal end of the femur, are present. The mental suture is beginning to fuse. The next topic going to discuss is dental age, the age indicator applicable to childhood dental development and the eruption of teeth has been long regarded as the gold standard. tooth developments include the both crown and root has been seen as being the less impacted by influence attributable to sex, nutrition and ill health than bone growth and development. Dental development has been considered to be so much more tightly tied to chronological age than the other skeletal indicator that in the events of inconsistent estimates from diverse skeleton sites, dental age has been given priority. Discrepancies have been attributed to the greater effect of environmental variability on bones growth. However, there is a reason to regard the assertion with some skepticism to at least the generalization embracing all the age of childhood as cited by Cagg and Elio in 1999. Continue the Cagg and Elio's investigation of discrepancies between the dental and skeleton age and how these track chronological age. Smith in year 2004 evaluated the 6-year longitudinal data for a Montreal sample of 42 boys and 36 girls aged between 10 to 15 years. Among her conclusion was that the result from the Montreal French-Canadian sample shows that while for a sample of individual skeletal and the dental age matches reasonably well, there is a considerable individual variation among the modern children is the timing of skeleton development relative to that of dentition. Nevertheless, a skeleton age is excessed by dental age by 2 years or more during adolescence is relatively unusual. Age of infant below the 6 months from a skeleton. The ramus of the mandible is short, oblique and forms obtuse angle with the body. The coronoids process project about the level of condyloids process. The mental formation remains near the lower margin of the jaw. Body is shallow for 6 months to 2 years. Outbreak of almost all the temporary teeth. Emergence of ossification center in the head of humerus, femur, ulna, tarsal and carpal bones. Closure of the anterior fontanelle at about 1.5 years. 2 to 6 years. The appearance of center of ossification in the epiphysis of long bones. Closure of metopic, union of condylar parts of occipital bone with the squama and basi-occipital, blending of greater and lesser tubercles to head of humerus. 6 to 12 years, union of rami and ischium with pubic at the age of 7 to 9 years. Ossification of pisiform bones occur at the age of 9 to 12 years in female. Union of lateral epicondyles of the humerus with the shaft. Shedding of all temporary teeth and eruption of all permanent teeth except the third molar at the age of 12 to 14 years. Appearance of secondary sexual character around 12 years, 12 to 18 years. Fusion of upper end of radius with shaft, fusion of olecranion on the ulna, eruption of third molar teeth with calcification of root of all the previously erupted teeth, union of lower ends of radius and ulna with the respective shaft. Now I am going to discuss the age 18 to 25 years. Fusion of epiphysis of long bone with their respective shaft, fusion of iliac crest with ilium, ischial tuberosity with ischium, fusion of coracoids and acromion with their respective bodies, union of the epiphyses at external ends of the clavicles, the secondary center in the pelvis, and the articular fits at the ribs usually get completed at the age of 20 to 25 years. Bony replacement of the cartilage between the basi-occipital and the basi-phenoids commence at about the 17th year in both sexes. Union is completed by 22 years in female and 24 years in male, usually 24 to 35 years. Closure of the lamboid suture is not complete before 50 years. Through coronal suture get closure at the age of 40 years. At the age of 40 years, the articular surface of lumbodorsal vertebrae shows the leaping, loss of joint space, presence of punch-out area of the osteoporosis. X-ray examination shows such changes. First in the glenoids fossa of the scapulars, leaping because the valves advance by the 45 to 50 years, but does not get complete before 60 years. Above 50 years, in old age, the bone density is very low, long bone become lighter and brittle, skull become thinner and lighter, and hence the more liable to fracture from even slight violence. Closure of mastoids, occipital, squamous and peritomastoid suture will occur in very old age. Parietal suture may not even close throughout life. Above 60 to 65 years, the angle of lower jaw open out and the medico-legal angle become obtuse. Manubrium and the body of sternum may fuse above 60 years. The calcification of the laryngeal and the costal cartilage become more apparent. Now determination of race from skeleton remains. A Caucasoid's cranium is long in length, narrow in breadth, and the high in height. The sagittal contour is round and exhibit a somewhat sloping forehead in comparison to negroids or mongoloids crania. The occipital profile is rounded and it exhibits the strong nuchal muscle marking site as the Skinner and negroid's cranium is long in length, narrow in breadth and low in height. The sagittal contour is flat and the occipital profile is quite rounded. Skinner and Lazenby in year 1983, the flatness of the sagittal contour is due to post-brachmatic depression, a state that occurs frequently in the negroid's cranium. Skinner and Lazenby describe the negroid's forehead as steep, but L. Nazar and the McWilliam describe the negroid's forehead as a rounded. According to Vass, again referring to the year 1975, Aldioids et al. Study the negroid's cranium exhibit thicker parieto-occipital areas than Caucasoid's crema. The mongoloid's cranium is the long in length but can frequently appear round instead of long. The mongoloid's cranium is broad in breadth and average in height. Categorized between the high Caucasoid's cranium and the low negroid's cranium, the occipital profile is angular and nuchal muscle marking are moderate. The sagittal contour is arced due to the keeling of the skull vault. Racial differences in skeleton structure originally arose when the small genetic changes develop in population isolated by geography. Now, as the migration increases worldwide and the inter-race marriage are also endorsed, thus the people of different racial background intermix and the progeny of those individuals is harder to differentiate. Till there are some key features of the skull that can help forensic investigation. First one is mouth. Whites tend to have the smaller teeth with significant crowding and impact the third molar. Black not often have crowding and the upper teeth often projected outwards. The second point is that the palates in American Indian, the palate is elliptical with the U-shape angling at the back teeth. In black, the palate is hyperbolic, a perfect U-shape with the straight lines. And in whites, the palate is parabolic with the end of U flaring outward. The third point is that the incisor. American Indian and the East Asian, both of Mongoloids ancestry, have the incisor shovel-shaped. Black and whites both have blade-form incisor. The next point is the nose. Whites have the long and narrow nasal aperture with a high bridge and a sharp nasal sill. The nasal aperture of black has short and the wide with a low bridge and a gutter or the tuft-like nasal sill. The nasal aperture of the American Indian is medium size with both a medium bridge and nasal sill. The next differentiating point is the mastoid process. The black have the wide bony projection, whites have narrow and pointed. American Indian, a secondary smaller projection form on the back surface of the mastoid process. The next topic is method for racial identification. Racial differentiation can be determined through the use of anthroposcopic or the non-metric methods. Many physical characteristics found on the skull can be analyzed non-materially in order to assess the race of an individual. When trying to identify the race of an individual, most anthroposcopic methods tend to focus on the craniofacial region of the skull. The best trait for determining race tends to those found around the nose, mouth, and cheeks. Krogman and Scan describe an anthroposcopic method used by Todds and Tracy in year 1930 to determine the racial affinity from Negroids and Caucasoids skull. Todd and Tracy focus on the 5 descriptive traits: supraorbital ridges, upper orbital margins, glabella, and the frontonasal suture and interorbital distances. Under each of these 5 descriptive traits, Todd and Tracy look for the 2 contrasting variations which they believe to be racially connected. The supraorbital ridges were either mesa-like or undulating. The upper orbital margin were either sharp or blunt. Glabella was either round or depressed. The frontonasal suture was either plain or beetling, and the interorbital distance was either narrow and wide. 2 types of skull were found, a U-shape and the M-type, both distributed throughout and the 2 races. Now your long bone can tell me how long you are or your heights. Estimation of heights from the long bone, how tall you are really. Giles and Hutchinson in year 1991 have reviewed the major source of extraneous variation in attempting to determining a true stature. This includes the average variation of nearby the inch attributed to the time of day gravity pulls down to the vertically oriented during the course of a normal day. The measurement technique and the variation among the measures introduce inaccuracy from the half a centimeter to several centimeters. The greater error usually attributable to the medical, police or correctional personnel untrained in measurement techniques. Trained measurement using a freestanding anthropometer on shoeless subject achieve the greatest accuracy and reproducibility in the measurements, and even the small variation persists. Noticeably, inaccuracy in the recording heights of the living can result from systematic biases and the random error to simple over optimism. Thank you.